nitroglycerin to get rid of some of the spasm.
Do you know what nitroglycerin is?
So now in the balloon, we open up the critical blockage.
Vasodilator.
And we still see a lot of thrombus in the vessel past the blockage. So we're going to put what's called the export catheter back down and withdraw a little bit more clot from there. So after one pass with the export catheter and one inflation of the balloon, the other is open and we're able to see beyond the blockage now and see what work needs to be done to restore blood flow to the artery. Now,
Okay.
we have the export catheter way down.
So anyway, let me give you some notes to
way
write
down
on that.
the blockage itself.
Oh, wait a minute. I didn't stop him?
Clot as we pull the catheter back through the artery.
All right, so what are you going to write down for an angioplasty? My notes have a mechanically widening a blocked artery. Does that work? Okay. Mechanically widening a blocked artery. So when I put the catheter in there and inflated a balloon, the balloon just pushes the plaque against the wall of the vessel, and then that opens up the artery. So mechanically widening a blocked artery using a catheter with a balloon, I guess, would help you to recall this. All right, once they get the vessel opened, they put a stent in there. And what a stent is, it's a vessel dilating spring. A vessel dilating spring that holds the vessel open. And when you're looking at a chest x-ray, you will see the stent. It'll look like you left your ballpoint pen in your pocket, and the spring that you see in a ballpoint pen will show up in the patient's x-ray. But that's just that little wire spring that's holding a vessel open in the heart. So you'll see stents on x-rays.
And does that stay there for the duration of the life?
Yes. Yeah. Hopefully it doesn't become dislodged or moved, because then they'll need to go in and fix it.
Yeah. Wow.
All right, and then for CABG, or coronary artery bypass graft, that's taking the patient to surgery, possibly opening up the chest. And bypass the occluded vessel. So bypass the occluded vessel with another blood vessel from the body. So you can put that down, then I'll explain this some more. With another blood vessel from somewhere in the body. Yes. So they could take the saphenous vein from the leg. They'll find a really good portion of the vein and just cut that, and then use that piece and bypass the occlusion, and then just sew it in.
What do they do with the vein? Like what they cut off of?
The rest of it, they'll throw out. Like they'll find a good piece, and then they throw part of the
From somewhere, like the part that was connected to, do they like close that?
Yes.
Oh, okay.
Another popular vessel to use is the mammary artery. They take it from the mammary artery and are feeding breast tissue, and then just reroute it over to the heart and sew it into the heart so that it can perfuse the heart So when you take it from breast tissue, then new vessels can grow in there if there isn't enough blood supply going into breast tissues. It's not like the breasts die because you've just taken away the blood vessel, but there is collateral circulation. So those are the most commonly used vessels. The saphenous vein from the legs. All right, to diagnose heart muscle dysfunction and valve dysfunction, then an ultrasound is used, and it's called echocardiography. So it's by holding the ultrasound device in the hand and just doing it over the chest, or they can also go into the esophagus and also get a really good look at the heart through the esophagus. So down here it says this is a trans-esophageal echocardiography demonstrating significant mitral valve stenosis. So trans-esophageal means they put the probe in the esophagus and they're looking at the heart through the esophagus because it's so close to the esophagus. Echocardiography, they're using ultrasound to get a picture of the heart and the valves. And what they're seeing is, it shows the left atrium, the left ventricle, and the mitral valve is very narrowed. The only thing I have on my notes for that is ultrasonic waves create a picture of internal organs. Is that something you already know, or do you want to write that down? Ultrasonic waves create a picture of internal organs. All right, I'm going to read a scenario that's very typical of somebody who has chest pain and they're having an MI. It says a 60-year-old woman comes to the emergency department with several hours of crushing substernal chest pain. Previously, this occurred while she was exerting herself and would abate with rest. This time, however, it developed while standing at work. The pain is severe, radiates down her left arm and up to her left face, and is causing her to feel sweaty, nauseated, and lightheaded. Her medical history is notable for hypertension, high cholesterol, and a family history of heart disease. Her coworker calls for emergency help, and she is given sublingual nitroglycerin and oxygen, which lessen her pain. Does that make sense to you? Why nitroglycerin is given to somebody who's having chest pain? It dilates the coronary vessels, and now you've got more perfusion going to the muscle, and of course, when you get better perfusion, the pain goes away. Oxygen delivered to ischemic tissue prevents necrosis. She is given aspirin therapy. What does that do? Right, it prevents blood clots. And thereafter is transported to the local emergency department where an ECG shows ST segment elevation. So there's just a change in the way that the EKG looks that indicates that there's muscle damage. On examination, she is diaphoretic, tachycardic, in mild respiratory distress, and obviously still in pain. A chest x-ray is clear. So you can't take a chest x-ray and tell that somebody's having a heart attack. A cardiac troponin assay and creatine kinase, MB, levels are moderately elevated. And we'll write down normal values for that, or do you guys already know that?
I know that's what they look for, though.
Okay, so we'll write those down in a minute. This patient has classical symptoms of angina, which is chest pain that is presumed to be due to coronary ischemia. Coronary ischemia is lack of oxygen to the heart muscle tissues that are dependent on the blood flow from the blocked vessel. This usually affects the left ventricle, but occasionally may affect the right side of the heart. Before the presentation that brought her to the emergency department, the patient's symptoms would have been classified as stable angina because her symptoms abated at rest. Now, her symptoms would be considered unstable. She most likely has an occluded coronary artery that, if it persists, may result in a more extensive damage. Her elevated cardiac troponin and CKMB, these are cardiac proteins that are leaked into the bloodstream when there is heart damage, such as ischemia. These levels already indicate that there has been cardiac injury. So there is little time to waste in preventing more heart damage. She therefore undergoes emergent left heart catheterization, not only because it would be diagnostic for occluded vessels, but also because there is a chance that the catheterization may in fact be therapeutic. An occluded coronary vessel can be visualized and opened successfully by means of angioplasty and possibly placing a stent to maintain the patency of the opened artery. All right, so that's typically how patients present. They have the chest pain, they're brought to the ER, they're rushed to the cath lab because time is so precious when you've got lack of oxygen to the tissue. So they want to get them to the cath lab and try and get perfusion reopened to that area of the heart before there's heart death. So the lab values for looking for cardiac injury, the first one is serum troponin. This is an enzyme that is released from the myocardium 2 to 3 hours after myocardial injury. So 2 to 3 hours after the injury. So you could check the blood levels of the patient. So they're having chest pain, you draw blood, and it won't even show up. So it takes like 2 to 3 hours before you can actually measure it in the blood. It peaks in 14 to 20 hours and then goes back to normal in 5 to 10 days. So a normal blood level for serum troponin is 0.1 nanograms to 3 nanograms per ml. I don't like having you guys memorize things, but I know that is a test question when you're studying for your test in 2 weeks. It does ask you for a normal blood level for serum troponin. And then CKMB, the creatine kinase myocardial band fraction. It's another enzyme released into the blood during myocardial injury. And I don't have the normals written down. PNP. Okay, so no normals needed. So I don't have those written down. So it is a marker of injury, and that's all you need to know about it. All right, let's take a 10-minute break so that you guys can get up and stretch your legs for a bit. And then it looks like we get into EKG after that.